Good evening, dear friends. Let us see the Orthopedic INI-CET Recall 23. The exam just is over. Okay, from PrepLadder, we'll do it for ortho. Okay, so totally there are around 8 questions. Don't worry, I'll finish within 10 minutes. Okay, we'll move on to the, okay, right, we will see the questions. Just what is the answer? Why? That's the answer. Very short. Right. Which of the following rib is fractured in the X-ray given below? They had given an X-ray and they had given 2, 4, 5, 6. Okay, 2, 4, 5, 6. The choices. Just it is a test for us how to counter rib. How to counter rib. Just I'll show you how to counter rib. This is, I'm able to see a fracture here. I think you'll be able to see a fracture here. Okay, right? Okay, so I will count from the normal side. Okay, how to counter rib. First rib, second rib, third rib, fourth rib, fifth rib, sixth rib. Okay, so like that it goes on 6, 7. Okay, like that it goes on like that. So see, when I count the rib, first rib I am not able to see any fracture. Second rib, I am not able to see any fracture. Okay, third rib, I am not able to see any fracture. Fourth rib, I am not able to see any fracture. Fifth, I am not able to see any fracture. The sixth rib, there is a fracture. There is a fracture. When you see it now, okay, slowly when you count it, you are able to see a fracture here, and that is the sixth rib. So the right answer is 6. Right answer is 6. We'll move on to the next question. You see the diagram. Excellent diagram. There, see, I am able to see redness in the radial half of the finger of the hand and blanching in the ulnar half of the hand, palmar surface. What is the name of the test performed in the image given below? Allen's test, Barbeau's test, Homan's test, Adson's test. 4 names they had given. See, the right answer is Allen's test. The right answer is Allen's test. Why Allen's test is the right answer? I will tell you what is Allen's test. Allen's test is a test performed to find out the patency of the deep palmar arch. It's a test to find out the patency of the deep palmar arch. What is that? In my hand, I can demonstrate it very easily. And this is a very, very important test that should be done before pricking the radial artery. When you are in a situation to prick the radial artery, where you will prick the radial artery, I have to prick it for collecting blood from the radial artery, arterial blood. I want to do arterial blood gas analysis, ABG. Before doing ABG, common artery that's selected is radial artery. Before pricking the radial artery, you should do Allen's test. You should establish that there is patency of deep palmar arch. There is no problem in the collateral circulation of the radial artery. Okay, deep palmar arch is patent. If it is not patent, you are not supposed to do an Allen's test. So what is this Allen's test? You compress the ulnar artery, compress it, ask the patient to do, okay, close the fingers, close the fist, open like this. Okay, for 10 times. Okay, yes. There will be blanching. When you release the ulnar artery, there will be capillary refilling. You will be able to see the pinkish, that plethora of the hand. Again, you do compress both the radial artery and ulnar artery. Make the hand like this, close the fist like this for 10 times. Release the radial artery this time. Again, there should be capillary refilling. Okay, this says that the deep palmar arch is patent. You know, deep palmar arch is made up of radial artery and deep branch of ulnar artery. Radial artery and the deep branch of ulnar artery. So, if the deep palmar arch is not patent, when you prick the only artery, radial artery, which is supplying the fingers of the hand, if it undergoes vasospasm, it may cause gangrene of the finger. Very dangerous situation. This is the significance of Allen's test. This is the significance of Allen's test. It's an excellent clinical test to diagnose the patency of deep palmar arch. Side by side, you should know what is Barbeau's test. Barbeau's test is a test to diagnose the patency of deep palmar arch. In that you are using a pulse oximeter probe. Pulse oximeter probe. You are seeing with a probe, pulse oximeter probe. Okay, that is called a Barbeau's test. It's an improvised form. This is purely clinical. This needs a pulse oximeter. Hohmann's test is no way related to this. That is a thing to DVT, deep vein thrombosis, that you know, the calf muscle, you know that. Adson's test again, it's a test to find out if there is any thoracic outlet obstruction. For example, if you have a cervical rib, the patient is having a cervical rib, ask the patient to abduct the upper limb to this level 90 degree, right? Ask the patient to turn his head to the same. For example, I am suspecting a cervical rib and a thoracic outlet obstruction on the right side. I'll abduct the upper limb to 90 degree like this. Ask the patient to turn the head to the same side. Palpate the pulse. The examiner palpates the radial artery pulse. It will be palpable. If you take a deep breath, the pulse will disappear. It says that I am having a thoracic outlet obstruction, probably due to a cervical rib, and that is called Adson's test. Time honored, this picture is given in our surgical DAS. Okay, so now you know Allen's, Barbeau's, Hohmann's, Adson's. This is obviously the question they are asked in our INICET is about Allen's tests. Coming to the third question. A 40-year-old male patient presented to the emergency room with the history of fall and complaints of pain, swelling and prominence of the right shoulder. The X-ray of the patient suggests tear in which of the following ligaments? That's the question. You should see the X-ray. When you see the X-ray, this is the acromial end. This is the acromion. This is the acromion. This is the acromial end of the clavicle. You see the space between the two. The gap is too much. This is not normal. This is not normal. Okay. Normally, the tip of the acromial end of clavicle should be with the acromion. It should be here. It should be at this level. Wide open. Here when you see, it's wide open. So this X-ray very clearly says that this patient is having acromioclavicular joint disruption. Acromioclavicular joint disruption. If it is acromioclavicular joint disruption, what are the ligaments that are disrupted? That's the question. Coracoclavicular ligament, choice A. Coracoacromial ligament, choice B. Both of the above. Glenohumeral ligament. Obviously, the answer is both of the above. Obviously, the answer is both of the above. Coracoacromial ligament plus coracoclavicular ligaments. I will show you the diagram. Very nice diagram. You just see, this is the normal shoulder joint X-ray. You see the acromial end of clavicle and acromion. They are in the same line. They are in the same line. You see the X-ray here. Wide gap is there. This is the X-ray that's given in your exam. Wide gap is there. So clearly this says, clinically, you will get what is this? This classical sign, clinical sign, a dip in the shoulder. Okay, this is called step sign. This is called a step sign. That sign, the classical sign, no? Step-like thing here in the clavicle. Now you see the shoulder. A classical step sign, a classical clinical sign of acromioclavicular joint disruption. Okay. What has happened here? This ligament which connects the acromion with the clavicle is called acromioclavicular ligament. Acromioclavicular ligament that attaches the coracoid process to the acromion. It is called coracoacromial ligament. Coracoacromial ligament. Right? Both these ligaments are damaged in a case of AC joint, acromioclavicular joint. See, this is the acromioclavicular ligament. This is the coracoacromial ligament. Both the ligaments are torn in case of acromioclavicular joint dislocation. That's the question they had asked. And the third question they had asked is, they had given an X-ray like this. Which one of the following features suggests malignant transformation of exostosis? Exostosis is otherwise called osteochondroma. We all know this is the most common primary benign bone tumor in a young child. Primary benign bone tumor. You know this is because of a perverted activity of the cambium layer of the periosteum. All these things we had seen. So what happened? What happened? This cartilage. Which of the following features suggests malignant transformation of the osteochondroma? This is the question. That's the question. You see here, You are seeing a metaphyseal growth, and this is growing away from the epiphysis. This growth is growing away from the epiphysis. This itself says that this is an osteochondroma. This is an osteochondroma. 4 choices they had given. Cartilage thickness more than 2 centimeters. Bone marrow is continuous with the parent bone. The cartilaginous growth goes towards the joint. The cartilaginous growth is going away from the joint. And the cartilage thickness more than 3 centimeters. This is what is given the choice. In the 4 choice, one feature highly suggests a malignant transformation is this. Cartilage thickness more than 2 centimeters. Cartilage thickness more than 2 centimeters. I will tell you the criteria. Features suggestive of malignant transformation of osteochondroma from our standard textbook or the standard textbooks. He says sudden unexplained pain in osteochondroma, because as a rule, dear friends, we know that exostosis is a painless condition. When pain happens in exostosis, you should think of 3 possibilities. 1, fracture of the exostosis. Number 2, bursitis of the exostosis. Bursitis, adventitious bursitis. Number 3 and most important thing is malignant transformation. It's a rare possibility, but you should know. Pain should not happen in exostosis. Sudden, acute, unexplained pain. Think of malignant transformation. Sudden increase in size. Think of sudden increase in size of osteochondroma exostosis. Think of malignant change. Thick, bulky, cartilaginous cap more than 2 centimeters. This is what given the standard textbook, and it's an MRI finding. It's an MRI finding. Radiology textbook says this. Ortho textbook says this. Thick, bulky, cartilaginous cap, size more than 2 centimeters. Development of, the 4th thing, development of soft tissue mass with or without soft tissue calcification. And 5th point, dispersed calcification within the cartilaginous cap. Even when you take an X-ray, you can see dispersed small mottle like calcification, specks of calcification. We have to suspect malignancy. So, thick, bulky, cartilaginous cap more than 2 centimeters, which is an MRI finding, is the correct answer in our exam. Which one of the following features suggestive of malignant transformation of exostosis or osteochondroma? The 4 choices, more than 2 centimeters is the right answer. Yes. Then, coming to the 4th question. What should be done as an immediate measure for ongoing bleeding in a patient with pelvic bone fracture? Okay. So, I think in the question bank, I discussed with my students. They said that patient presented with hypovolemia, hypovolemic shock-like feature. That's what they said. Along with this, some students said that it is associated. You all had written the INICET and you will be knowing that. So, when there is an immediate, what is the immediate measure? Patient is bleeding. Patient is bleeding. It's a pelvic injury. It's a pelvic fracture. I accept, but patient is bleeding. In the 4 choices, what they had given: rapid blood transfusion, external fixation, internal definitive fixation, use pelvic binders or any a bed sheet or a pillow cover tying around the pelvis. It's like a pelvic binder. 4 choices they are given. See, dear friends, it's an emergency. It's a resuscitative procedure. Patient is going for hypovolemic shock, like the patient is bleeding actively. The first thing you have to do is a rapid blood transfusion. There is no doubt. The 4 choice, first thing what I will do is give a massive blood transfusion, because in our 100 onliners we had seen amount of blood loss in pelvic injury 3 liters. In shaft of femur 1.5 liters, 3 liters, a massive blood loss. So rapid blood transfusion is the first thing you should do. While doing that, the second measure in the 4 choices you should do is use a pelvic binder. Use a pelvic binder so that destruction or displacement of the fracture won't happen and further bleeding may be prevented. So use a pelvic binder. 2. Number 3, after that, do an external fixation. Do a pelvic external fixation. Finally, after the patient is stabilized, you can go for definitive internal fixation. This is the correct order in these 4 choices, dear friends. Yes. Next question, 5th question. A 25-year-old young male brought to the emergency after violent road traffic accident with fracture femur. After 12 hours, patient developed dyspnea. See, this is very important. After 12 hours, patient is developing dyspnea. He is confused. The orientation is not clear. Mentation is not clear. He is confused with petechial rash in chest and axilla. In chest and axilla. What could be the diagnosis? What could be the diagnosis? Definitely it's not head injury. It is not chest injury, chest trauma. Okay. So if it is head injury, this is after 12 hours, number 1. Petechial rash they had given. Patient is confused. That's what they are telling. They are not using the word unconscious. Loss of consciousness. They have not used the word confused. If it's a chest trauma, patient will be having paradoxical respiration. Fat embolism is the most probable and correct diagnosis. Hemorrhagic shock is not the answer, because in hemorrhagic shock, main thing is they won't give weightage for the petechial rash. It will be hemorrhagic shock. What there will be tachycardia, hypotension. Okay, right? So that will be the picture. So it should be fat embolism, otherwise called ARDS. Okay, ARDS. We had discussed this in image-based session. I had shown you, and you should know why this is fat embolism. I will tell you. This is what is called Gertz criteria. Gertz criteria. Major criteria, minor criteria. In major criteria, patient will have petechial rash in the chest, axilla, face, very characteristically in the lower conjunctiva. Lower conjunctival petechiae. Saturation is less than 60. X-ray shows a snowstorm appearance. Cerebral symptoms unrelated to head injury. See, patient will have just confusion, unrelated to head injury. Minor criteria comes tachycardia, pyrexia, oligoanuria, fat globules in the sputum, higher ESR, a jaundice. 1 major criteria plus 4 minor said to be positive. Okay, the definitive diagnosis is made by what is called a GERD test, fat embolism, a GERD test. What is GERD test? We had discussed this already in image base. I had discussed this. Just I will tell you once more. Take patient's venous blood, 5 ml of venous blood. Just have a muslin cloth, a jet black color, dark colored muslin cloth. Pour the venous blood over the muslin cloth. You can see dripping of the blood happens through the cloth. Over that dark black color cloth, you can see a golden yellow metallic sheen of the golden yellow globules. With your naked eye, you can see what are they? They are fat globules. Direct evidence of fat embolism. Direct evidence of fat embolism. You can see micro yellow, golden yellow fat globules over the sheet, over the cloth. This is called GERD test. This is a bedside test. Anybody can do the test. 5 ml of patient's venous blood is enough. And when you see that, there is no second differential diagnosis. It is fat embolism. GERD test. Okay, dear friends. So we will move on to the next question. A 30-year-old man had a RTA, sustained injury to the right upper limb. He is not able to flex the distal interphalangeal joint of the 4th and 5th finger, and he is not able to hold papers in between the fingers. Very classically, this is an ulnar nerve injury. This is an ulnar nerve injury. Obviously. Okay, ulnar nerve injury. Ulnar nerve injury usually this is an ulnar nerve injury. Where is the lesion they are asking in the body? Medial epicondyle, lateral epicondyle, olecranon, spiral groove. It can't be spiral groove because spiral groove is concerned with radial nerve. It can't be olecranon, is not a thing. Lateral epicondyle is not related. It should be medial condyle. This is the right answer. The medial condyle is the right answer. Okay, so why this? What are the muscles that are affected? Flexor carpi ulnaris, medial half of the flexor digitorum profundus. Because flexor digitorum profundus is a hybrid muscle supplied by median nerve and ulnar nerve. The medial half is by your ulnar nerve. And why he is not able to hold papers in between the fingers? So this is called cord test, because dorsal, the palmar and dorsal intraosseous are affected. So this is called a cord test. This is called a cord test. For palmar intraosseous, you will do a cord test. For dorsal intraosseous, what you do? You just ask the patient to pronate the hand, rest it on a table, ask him to spread the fingers like this. With the middle finger, he should be able to do like this, and this is called the Igawa test. This is called Igawa's test. So for dorsal intraosseous, it is Igawa test. For palmar intraosseous, it's called Cod test. So he is not able to, because ulnar nerve supplies the palmar and dorsal intraosseous. So intraosseous is gone. That's why he is not able to hold the papers in between the fingers. So he is concerned with an ulnar nerve injury at the level of medial epicondyle here. Medial epicondyle. Yes. 8-year-old girl presented with bone pain in lower limb and upper limb, having features of hypothyroidism. Discolored rash over the face and chest. X-ray showed the following feature. This X-ray, same thing, almost we had seen in 100 onliners. I have shown you this X-ray. This is what is called a shepherd-crook deformity. This is what is called a shepherd-crook deformity. Shepherd-crook deformity. So, a female child, 8 years, hormonal imbalance, having discolored rash, what is meaning? Cephalous spots. So, the diagnosis is McCune-Albright syndrome. Diagnosis is McCune-Albright syndrome. McCune-Albright syndrome, what is McCune-Albright syndrome? Polyostotic fibrous dysplasia. McCune-Albright syndrome is a combination of polyostotic, fibrous dysplasia plus precocious puberty, plus Cephalous spots. So these are the combination. So McCune-Albright syndrome is polyostotic fibrous dysplasia, precocious puberty, Cephalous spots. That's called McCune-Albright syndrome. It can't be papillary carcinoma of thyroid with metastasis. Obviously, papillary carcinoma, it has lymphatic metastasis. They should be having the lymph nodes in the neck. It won't cause a lesion like this. Monostotic fibrous dysplasia means it will involve only single bone. It is devoid of endocrine manifestation. If McCune-Albright syndrome, Langerhans histiocytosis, what is Langerhans histiocytosis? Histiocytosis X, it contains eosinophilic granuloma like picture. They should be having multiple punched out lesions in the bone. It is not like this. You are able to see this is a normal femur. Here the proximal femur is bent like a shepherd crook. Very, very classical of polyostotic fibrous dysplasia. Shepherd crook deformity plus Cephalous spots, and the girl is having hypothyroidism. That means she is having endocrine pathology also. So definitely, other things they had missed. She should be having a precocious puberty, and that is classical of McCune-Albright syndrome. So these are the questions they have asked, dear friends. Hopefully, most of you would have written everything correctly. Simple, straightforward questions. All the best, dear friends. Thank you.
Subscribe and press the bell icon so you never miss an update from PrepLadder.